Hello, my name is Sandra Herrera, and I'm doing my evidence-based presentation on screening for mental health risks in schools. According to the National Alliance on Mental Illness, 20% of youth ages 13 to 18 live with a mental health condition. 11% have a mood disorder, 10% have a behavior or conduct disorder, and 8% have an anxiety disorder. These numbers have a great impact in our society. 50% of all lifetime cases of mental illness begin by age 14 and 75% by age 24. The average delay between onset of symptoms and intervention is 8 to 10 years. 37% of students with a mental health condition age 14 and older drop out of school, the highest dropout rate of any disability group. 70% of youth in state and local juvenile systems have a mental illness. Suicide is the third leading cause of death in youth ages 10 to 24. 90% of those who died by suicide had an underlying mental illness. These startling numbers acknowledge the fact of the need to mental health screen. Mental health screenings are a key part of youth mental health. Mental health screenings allow for early identification and intervention. Research has shown that targeting symptoms early leads to better outcomes. Early treatment may also lessen long-term disability and prevent years of suffering. Healthcare screenings are common in this country. Most kids are unable to go to school. Why are schools an ideal choice to do this? Schools can reach large segments of the population, including those who do not have insurance. Schools begin early in life, and they entail periods of prolonged engagement during which effective intervention strategies can be implemented. Children are likely to seek help from people with whom they already have a trusted relationship, such as a teacher. Much research has been done on this topic, and they show that numerous systematic and meta-analysis studies confirm to the fact that high-quality, well-implemented, school-based mental health interventions can affect meaningful change for children and young people. There's also broad agreement that an integrated approach to provision that offers a synthesis of universal, targeted, and indicated interventions is likely to be the most effective model for schools, offering as it does increased intervention exposure for those who need it the most. What are some implementation considerations schools will need? First, training and good clarification for school staff. They would need to improve awareness of mental health and mental health disease. There has to be consistency of screening across informants, understanding of how to score and use the data generated. There has to be good communication with parents, and a referral and intervention practice following screening. Measure selection and approach to screening. Schools need to consider which tests they're going to use. Some are free, others cost money. Some measure specific mental health illnesses such as depression and ADHD. Others are a wide-based test. How long will the test take? What age range will this be distributed to? Are we going to screen all kids or only the ones the teacher nominates? Each school needs to assess their needs and pick the right fit for their school. Informants. Who would be the ones providing the information? Teachers, parents, or the students? Teachers see the behavior of the students at school. They have experience with other children as a frame of reference. However, teachers might be wary about the time constraints. Parents had detailed info on behavior in the home context. But research has shown that they usually underestimate the internalizing difficulties of children. Self-report of students works only if the student is 7 years or older, due to literacy if they're below the age of comprehension. And usually, most students below the age of 7 do not have that self-awareness and competence in social understanding. So it's thought that multi-informant approach is recommended. Use and sharing of data. What happens next? The coordination of care. Universal screening in schools can only meet its ultimate aim of improving mental health and well-being if the data it produces is used effectively and efficiently. Are follow-up services established for those in need? Are they sharing the information with parents and external agencies that can help provide that care? What are the implications for practice? There is the thought that universal screening could result in high yield in a state of currently limited resources. The thought of false positives, where screening may cause unnecessary concern, and false negatives, where screening could cause unwarranted reassurance when a child may actually need further support or attention. There is the cost of the program. Who will they be screening? Is it going to be everyone or only those at risk? When is the screening going to be initiated? At kinder, school age, middle school, or into high school? And what is going to be screened? Is it going to be a general overall mental health assessment, or is it going to be focused on depression, ADHD, or suicide risk? Then there is the mental health stigma. Many parents might not want to give consent to have their child be assessed due to this mental health stigma. Therefore, that's the importance of education when you first implement a program, and good communication with parent and the community. Also, having an on-site clinical follow-up can address the problem with the false positive negatives. So in conclusion, we could all agree that mental health in children is an emerging public health crisis. The school system is a crucial component for early intervention and prevention. Screening as part of a coordinated and comprehensive school mental health program complements the missions of schools, identifies youth in need, links them to effective services, and contributes into positive educational outcomes valued by families, schools, and communities. Thank you for taking the time to listen to my evidence-based presentation. I hope you all learned about mental health in children and the need for mental health screening in schools. Thank you.